Good afternoon, folks. We thank you for joining us. I am Robin Colonel, and I will be your host and one of the presenters for today's presentation. So just for some housekeeping purposes, all lines are currently muted. We do encourage you to use our Q&A feature that's at the bottom of your screen there. Throughout our webinar, post any questions that you have, and we'll do our best to address as many of those as we can at the end of the day. So as a brief disclaimer here, our information contained in this presentation is for general information purposes only. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, suitability, or availability with respect to content. If you have not worked with us before, we want to provide you with our list of services that we offer for physicians in hospitals. We are very proud to know that we have assisted more than 5,000 providers across the Commonwealth with attesting to Medicaid meaningful use and Medicare and several of the other regulatory requirements for our providers and healthcare systems. So if you see anything on this list that you might be of interest to you, please reach out to us either through one of the contact methods we offered earlier, or we'll have a slide again at the end of the presentation as such. Your presenters today, as I mentioned, I'm Robin Colonel, and then joining me is Kelly Fountain. She is our transformation manager with our department, and we both work on several lines within the REC. So hopefully today you'll have familiar faces and voices with our presentation that you'll recognize. Our objectives for this 1-hour presentation is strictly around your performance feedback from the 2020 program year. So we'll talk about how to gain access to that. So if you're a new user or a new manager within your office, we want to help you get access to that feedback report. We're going to talk about how to navigate it and what information that you've gleaned from that, and then how to apply that feedback to improve your performance maybe for 21 and beyond. And then we'll talk about some other considerations and maybe some next steps that you might find helpful in improving your performance within the quality payment program. So let's just get right into talking about how to access your feedback report. So if you are new to your practice, or maybe you have a new role within your system, you need to update your HARP registration, and you can do that through a couple of different ways. If you're out on the QPP website and you go into your particular portal and it's going to ask you for login and password information, it'll let you register there. You can click on the link and it'll take you over to the HARP system. You have to have this HARP login and password to get into that QPP performance feedback, and then depending upon your user role access that you've listed within HARP determines what you're available to see and do within that personal portal for your organization. So depending on just some little things there to keep in mind, the website we've listed here is qpp.cms.gov, and then you can also use the HARP website that we've listed. Keep in mind that you must update your password every 90 days. When you set up your registration, you'll be asked some security questions, so I would encourage you to keep that information handy so that you can answer those. You'll be able to look at group and individual feedback reports, and then you can also ensure when you're reviewing this feedback report that your data is in fact accurate, and this gives you opportunity during this targeted feedback review period that happens once that feedback's been released. Gives you some time to review that and then make that request for any kind of appeals that's necessary. This HARP login is also where you would get make sure that your contact information is current with your organization, because this is how you'll receive some of the correspondence that's specific to your organization. And just as an aside note, once you get to the quality payment website, that qpp.cms.gov, you have the opportunity there at the bottom of the page to log in and sign up for some of their listservs. So we encourage you to do that as well so that you don't miss any important information coming from CMS regarding these programs. I've already mentioned that when you sign into HARP, you'll have to select your role within the system. And so there's different ones to pick from, depending on what you do in your organization. If you represent a practice, which is a single tax ID number, you must have a security official, and so that could be you as the office manager, or it could be someone else in your practice. But this gives you the opportunity to do your submissions for your group or your eligible clinician. And then also, if you're a part of an ACO, you'll need this access so that you can at least do your promoting interoperability submission. If you're a clinician, you can also sign in, and you'll have a little separate view from what the practice sees. This requires your NPI, your Social Security number, and then your PTAN, so that you can access those results only for you as a clinician. Now, if you're a single provider clinic, you're going to obviously see everything that your office manager can see in that perspective. But it does not support submission at this point, only review. So if you're a clinician who does their own submissions, and we have some who do, then you'll need to register as a security official under the practice more so than as a clinician. If you are an alternative payment model representative who will be submitting on behalf of that APM or an advanced APM, it requires a security official role. And again, you'll be able to submit that quality data, and you'll be able to review that quality feedback. CMS approved registry representative, again, they require a security official role. And then virtual group, same thing. You'll have to have a CMS approved virtual group, and it requires a security official. Now, a state security official for some of these, there are additional roles that you can have within that system, but ultimately, each organization, in order to submit for MIPS, has to have at least one person designated as a security official. And then that person can approve other folks for various roles within that organization. So I mentioned there at the bottom just some examples. You can have staff roles, you do have to have a security official, and then you can have a clinician role as well. So let's talk about the feedback reports. So when you sign in, you're going to see a screen similar to this one. Ideally, you would see the account home first, which is in that left banner over there in that dark blue bar. So it'll look a little different, but when you're on the actual home page for your account, you'll see what practices that you have access to, or what tax ID numbers. Maybe you're a larger group and you have multiple tax IDs. Then you'll have eligibility and reporting tab, and then underneath that one, you'll see performance feedback. And so you would click on that, and you could actually see the performance feedback at both the clinician level and the group. I do have a little reminder there that eligibility and reporting, that identifies your eligible clinicians and allows you to submit data there. It also not only identifies the eligible clinicians, it should list all of the clinicians within your tax ID that's tied to that tax ID. So if you have providers coming and going, it's always important to check that eligibility and reporting throughout the year just to see if they've been added or not. So we don't want to miss anybody. So again, you would click on performance feedback, and then you would see some options here as to the practice name, and then if you have more than one practice, they would all be listed here as well. And then you see there that little red circle says view practice feedback. That's where you would click, and you could look from the practice level, or you could see it from the clinician. So as a brief reminder in regards to final scores and payment adjustments, of course, your final score is what you use to determine your payment adjustment, and then that payment adjustment is determined by a couple of processes. One, your final score, and then the targeted review. So it's important to remember that you have, I think it's a 30-day window after receiving the reports. It may be a little longer than that, but that we have this targeted review process open. So that's your opportunity to appeal if you feel like you've been scored incorrectly. Once that review process is closed and CMS makes any adjustments, they could potentially go back and adjust that payment adjustment up or down a little bit based on that targeted review process. So maybe you've appealed, CMS says, yes, your score should be higher, and they'll have to readjust all of those payment adjustments, both just the payment adjustment for the neutral budget and the exceptional performer if you qualified for that, because this is a budget neutral program and we talk about how the losers fund the winners. So while it's final feedback report, it may not be final score, may not be final payment adjustment just yet in the year. So just keep that in mind. You'll want to check that again probably in another couple months. So based on the user guide and information we received back from CMS, this is where the scale falls for scoring. So if you had received a final score between 85 and 100 points, so you've hit that exceptional performer bonus, you're going to see the positive MIPS adjustment, and then you're going to see an eligible, or you're going to see that additional adjustment for being an exceptional performer. And note that it says subject to a scaling factor for both of those items. And to kind of give you an explanation of what that is, CMS goes and looks at where the scores fall, and then they, to keep this budget neutral, they identify just what they can give as far as a positive MIPS adjustment. And then they look into those folks who are exceptional performers, and since that's at a select amount of money, they determine how they can slide that around as well. And so, you know, the 85 score is not going to get you the same exceptional performer adjustment as a perfect 100 score. Same way with the positive MIPS adjustment. It's not a flat rate. If you scored between 45 and 84.99 points, you will see a positive MIPS adjustment. Again, that scaling factor is in there as well to preserve that budget neutrality, but you won't see that exceptional performer bonus. And then 45 points was the performance threshold for 2020. And so if you met 45 points, you're not going to see a positive or a negative. You'll receive that Medicare Part B standardized rate. Now, if you submitted data and you were scored and received less than 45 points, based on where you fell within that scoring, it determines what percentage of negative adjustment that you're going to receive. And so if you scored 11.26 points more than, or up to 44, then you're going to see some sort of negative adjustment there. And it won't necessarily be the full 9%, but it will be some. And then if you scored less than that 11 points there, you will receive that full negative 9% payment adjustment. So we know that during 2020, COVID-19 it literally impacted everybody. There was no way around it. It impacted all of our providers and all of our hospitals, and CMS recognized that. So they offered a few flexibilities within that. First was the extreme and uncontrollable circumstance hardship. Folks had the opportunity to apply for that hardship based on COVID-19 difficulties and then receive some relief there as far as reweighting of categories or possibly being exempt from reporting altogether. We saw that that actually rolled out in a couple of different phases. First, you applied for the hardship, then they extended the hardship deadline reporting, and then at some point CMS said, okay, if you've not submitted data and it's due to CMS hardship, we've extended that date to go ahead and apply that application and get that in there. They also did this early, the increased complex patient bonus. They actually went ahead and put that into earlier rulings and allowed you to get double the points for that. So ordinarily that would have been a 0 to 5 point bonus on your score after the categories were scored based on the complexity of your patients and those who are dually eligible for Medicaid. For 2020, they extended that and actually made it 0 to 10 points. So that added a little extra onto your final score, and looks like we'll probably see that for this year as well. And then finally, cost reweight. So originally CMS said, you know, we're going to suppress some of these cost measures because they're due to COVID, specifically around pneumonia, but there were a few others. And they were suppressing those measures. Nobody would be scored on those particular ones. Then they came back and said, you know, this is getting worse. We're not going to score anybody on cost. They made that determination early 2021. And so those points that would have been afforded to the cost category were then redistributed out to the other categories. And so you saw some changes there. If you were looking at your preliminary feedback reports, where those points went, it was a little different than what we had seen in the past. So you're looking at your feedback report, and we see final score and payment adjustments. And I apologize for this screen. And we've tried to get this one to be more clean and clear, but it just wasn't happening. But the pictures aren't so much important as to what we see from this payment, what you see from your feedback score there. So first of all, if you pull up that report and you want to look at providers and their individual data, you can do that. You can sort by clinicians, you can sort by the groups if you're looking at multiple tax IDs, and you can sort by your individual clinicians who qualified for payment adjustment. So you have some flexibility in how you review that report, and then you have different ways to download that data as well. And then you can download your payment adjustment reports into a CSV file by those same methods, connected clinicians, and the group score, and those that may be receiving an APM score as well. And then final MIP scores and each category scores are also visible, so you can see what your total score was and compared to total possible score for that category. Like in this example, we see that quality, they received 60 points out of the maximum possible 60 for that category. Improvement activities, they only received 10 out of the possible 15. Promoting interoperability, they received 25 out of 25. And then at the bottom of that same box, you see the awarded bonus points. And then the cost category is not applicable because it wasn't scored. If you had categories that were reweighted, this is where you would see that indication. So quality might have been 60 out of 85 possible points, and maybe promoting interoperability wasn't scored. So that's where you would recognize that you've had some reweighting. We talk about final score and payment adjustment calculations here. So I've mentioned this on a previous slide and maybe more than once, budget neutrality. So this system is mandated to be budget neutral, and that's why we talk about the whole losers, funding winners, and the penalties assessed is what actually makes the MIPS payment adjustment positive. That's all dependent on some things. Participation rates, number one, how many folks actually participated in the program versus who were not eligible. Then clinician performance, you know, where do you fall into that scale on the 0 to 100? Are you just meeting the necessary minimums to avoid payment reduction, or are you in that exceptional performer, you know, just exactly where your groups actually perform? And then threshold level. We know that's going to change each year. I mean, we're up to 60 points, and then next year's already been determined. I think in some final ruling, it's not final, but it's already being proposed for folks. So that's a moving target. So just keep those in mind. Those are things that actually influence your payment adjustment. We gave you some sample scores here. So I mentioned on the slide previous that you could see your final score and where each individual category was. If you click on down the page, you would get to this part where you would see each category, and then you'd have the opportunity to view details. And then you'd also see on that same page your final score and then what your MIPS payment adjustments could be. And while the slide may be a little small, the payment adjustment in this particular case is like 0.07%, but that exceptional performer bonus was 2.14. And so that's how their total payment adjustment was 2.2 for a perfect score. So we talk about quality specifically here. So we see in this particular feedback report, this clinician or tax ID, whichever it was, their total category score was 31.86 out of a total of 60 possible points for them. And then if you're within that category, looking at it at the portal, and you would see at that point all of the measures they scored you on, what measures they didn't score you on, and then at the bottom of the page, we would see how they calculated your total quality score. So they give you performance in relation to the actual quality measures, any additional bonus points, and then over the total maximum points eligible for that category, and then your category weighting. And then the final score, which contribute the category score that contributes to your final score. Promoting interoperability looks similar. You'll see your total category score there at the top as well. This one you are measured, on you are scored on all the measures that you submit. At the bottom of that same page, it would do the same thing. It would give you your base score points, any bonus points that was accumulated during promoting interoperability, and then total points eligible for that category. Now, category points is different than category weight. So there's maximum number of points actually from promoting interoperability is 105. So this person didn't apply for the bonus, and so they don't get the bonus points, and then their maximum points there is at 100. And then category weighting for promoting interoperability is 25% of your final score, and so the total contribution for this particular clinician was 22.75. Improvement activities is similar. It's a little different in that it calculates the scoring as far as the points related to high activity points versus medium activity points. If you remember, those score differently, and then if there's some special circumstances associated with your clinicians or your groups, like, rural, they're designated as rural or HIPS or things like that, the scoring looks a little bit different. It will also list those particular measures that you've submitted and then what their score is in relation to that particular measure. Like in this case, we see that somebody used the CAPS for MIP survey for the clinicians. That's considered a highly weighted activity, so it gives them a 40 points towards that maximum scoring. And then they also used the use of telehealth. Sorry, I struggled on that word. Use of telehealth services to expand practice access. That's considered a medium weighted activity, and in this case, they received 20 points. So now we're going to talk about application of feedback, and I'm going to turn it over to my partner, Kelly, and she's going to take us through the rest of the presentation.
All right, thank you, Robin. So now you have gained access to your feedback report. What do you do now? There is actually a whole host of information in this feedback report, and you can start at the surface level, and a lot of people oftentimes stop there. We recommend that if you can and you bear with us, you dig a little bit deeper. So here you'll see essentially quality feedback. For this year, because cost was reweighted, you're not going to see a lot of information around the cost category. So quality is going to be the place that you'll get the most feedback in particular. So here you're going to see how you perform against your peers that reported in the same fashion. It's going to tell you what your overall numerator, denominator, and what your data completeness was, as well as how many points you received. And it's going to break out those points based off of your performance points, as well as if you get any bonus points here. Now, this is important. Robin alluded to the fact that we have an open NPRM right now. That open NPRM has the potential to remove for next year those end-to-end bonus points, or even high priority or outcome points. So at the bottom right-hand corner of the slide, you'll see other high priority points and end-to-end reporting. This measure right here, so we're talking about preventative care and screening for high blood pressure and follow-up documented, you'll see that this measure, they received one end-to-end bonus point. So the performance was 9.48, however, they received 10.48 points. If they move forward with removing those bonus points, this practice would only be eligible for that 9.48 points, which isn't a huge deal. However, if you remove that from 6 measures, that's 6 points removed from your overall quality performance. So it does add up. Other things that you see here is kind of an overall trend. There's also a graph typically associated depending on how much data is submitted for a measure. For this one, you'll see kind of a bar, and it'll say the lowest benchmark to the highest benchmark. You'll see that for this measure in particular, it is a standard measure, meaning the closer you are to 100, the better the performance. This practice performed about the top 25% or so performance. They're almost in that final quartile. They're almost in decile 9 or 10 range, which is, well, they are in decile 9, but they're almost out of that 9 into the 10 range. So their performance rate was 89.21. You'll see here also essentially additional information associated with how many patients were in their eligible population, as well as a visual skew or scale of how you fared on that measure in particular. Now, you're going to have this available for every single one of the quality measures that you submit. If you submit from year to year, you can actually pull up from year to year your performance. You can look and say, oh, okay, for 2019, I submitted on high blood pressure and I fell in decile 6. In year 2020, I fell in decile 9. And look and see what your eligible population and your denominator is. If those are holding true, then you truly have an improvement. If you have a skew in one direction or the other, you may still have an improvement. However, it might just be, it might not all be an improvement, or it might not all be a backslide, if you will. So there's a lot of information available. Those deciles in particular is one area that I like to focus in on because I personally am a visual person. So I like to see where my performance falls against my peers on a specific measure. I'm competitive. I want to be towards the end. I want to be towards the top. However, sometimes just knowing that you fall in the average is ideal for people as well. So we'll go on to the next slide here. So this is how CMS calculates improvement scoring. And I will tell you that CMS is currently proposing to maintain improvement scoring here. Now, CMS is going to look at your overall performance as far as it goes for the quality measure. So this one is how many points did you earn for performance? And then how many bonus points did you earn for those measures? And then what was the potential or maximum number you could receive? Remember, you are required currently to submit at least 6 clinical quality measures to CMS, and each of those has a maximum performance score of 10 points. So that means 60 maximum positive points. And then you can get up to 10% for an improvement. And that has to be statistically significant improvement from year over. Now, CMS does the calculation of whether or not it's statistically significant. I have not seen more than a few percentage points improvement score added, but what they'll do is they'll factor in that improvement score, and that will go in before they factor in or apply it towards the category weight. So for this example here, they end up with a 22.43 out of 45 points. Again, just to kind of break down that formula there, is that it's an increase in the quality performance category achievement percentage score, so from prior performance period to current performance period, divided by the prior performance period to quality performance score. So it's that overall performance score divided by previous performance score times by 10%. So essentially, you do have to fully participate in this program in order to qualify, and you have to meet the data sufficiency requirements. So essentially you have to meet that data requirements. Now, thinking a little bit about the bonus points in particular. Currently, we still have means out there to get bonus points associated with end-to-end electronic. So this is when you are collecting and submitting electronically to CMS your CQMs, your clinical quality data information. In addition to that, you can actually earn additional bonus points associated with high priority or outcome measures. So 1 point associated with end-to-end, 1 point associated with high priority, and up to 2 points for an additional outcome measure. These measures, if you can select them, I highly recommend, especially at least for the 21 program year. 22 is one of those areas in which we still don't know if those are going to be on the table. You do have until September 13th to submit comments on the NPRM, and highly recommend, if you are comfortable, to do so, because this is something that CMS is currently proposing to remove. Now, promoting interoperability. On this one in particular, you're really going to see the basics associated with your feedback here. So this is just an example. You take the health information exchange objective. We all know that there are really 2 main subset measures underneath that objective. You'll have the first measure, which is support electronic referral loops by sending health information. You'll see your measure score, and then you'll see the second measure here, which is support by receiving and incorporating. And you'll see here 19 out of 20. If you did not receive full credit, CMS will essentially move or provide the top measures to improve or increase. So they're going to, at the very top of your feedback for each of the categories, show areas for opportunity or areas for improvement. If you did not max out on the performance, for example, if you got a perfect score on promoting interoperability, it is not going to show you opportunities for improvement. You're not really going to see a graph associated with promoting interoperability. You're truly just going to see what your measure score is and overall performance was for that measure in particular. So not as helpful as some of the others. However, it is something if you were looking from year over performance, it's a good indicator of reminding you. In 2018, we had 150 transitions of care electronically. In 2019, we had 90, and in 2020, we only had 20. That might be an indicator of what changed. Improvement activities in particular, you're going to see what activities you submitted on, as well as your total score and any special considerations. Now, this is really good for me, in my mind, for documentation's sake. So this is a clean, neat, orderly way to kind of document what you submitted to CMS for that program year in one kind of neat and tidy way and fashion. This really can be added to your audit prep binder in the event that you do get audited, so that you have your documentation in hand that says, okay, this is what I submitted, this is what I did, this is my documentation that supports that I did these improvement activities, and this is the score that I received associated with that, taking into consideration any of those special considerations in particular. All right, so not a lot of application associated with improvement activities, not a ton associated with promoting interoperability. Really, the two areas that you're going to have the most application for these feedback reports are going to be cost and quality. And unfortunately, we had hoped that we would have some information associated with the cost performance category and feedback from CMS this year, but because they reweighted the cost performance category, there is no feedback available. The only feedback that you can find in particular is if you are associated with an emergency room, so you may have some services associated with that. You might have items and services also. This is going to sit outside of your formal feedback report, so it's not going to be tied to your performance feedback for the 4 categories. It's going to be on the left-hand side of that feedback report in the QPP system. And you can take a look to see how many beneficiaries were associated with your tax ID and what were the costs associated for different procedures, as well as how many ER visits perhaps took place with those patients that were attributed to you. Typically with cost, you get a lot more information associated with that, and you can pair it up with the quality category. Ultimately, though, you want to take a look at what information is in your final feedback report. If it differs from what you submitted to CMS, you need to submit a targeted review. If it is incorrect in any fashion, you need to work with your advisor to submit that targeted review. Make sure that you are paying close attention to your numerators and your denominators for quality and promoting interoperability especially. Those two in particular are very sensitive to those numerators, denominators, and really just overall data completeness associated with those 2 performance categories. Improvement activities, you want to be cognizant of the fact that you have selected enough improvement activities. You haven't seen any improvement activities appear or disappear from your attestation. Again, in the event that any of those are different than what you originally submitted before the end of the deadline, you want to talk to one of your advisors and make sure that you go through the necessary steps to communicate with CMS and open up a targeted review. Now, Robin highlighted the fact that earlier this year, CMS essentially rolled out that costs would not be evaluated. They reweighted cost over, so we do not have any feedback associated with cost. Eligibility is one of those things that CMS has released the initial eligibility for the 2021 program year. Highly recommend that you log into the QPP system. While you're looking at that feedback report, go ahead and take a look at the eligibility. Also, take a look at the payment adjustments associated with your individual clinicians. It may be different depending on where those individual clinicians are coming from. If an individual clinician is associated with an APM, they may receive the adjustment associated with participating in that APM. It's not always 100% black and white kind of approach to this. So sometimes it requires digging a little bit deeper beyond just that landing screen for the payment adjustment. And again, if you have questions, please reach out to your advisor. They should be walking through your feedback report with you, but this is really intended to try and help you have a guide through this process. Now, one of the things that you should see is a complex patient bonus on your feedback report. Now, this complex patient bonus kind of sits outside of the performance categories, and this is really looking at the patients you see and what is the complexity associated with those patients. Historically speaking, this was looking at dual eligible or your HCC or risk score associated with those patients. So patients that are eligible for Medicare and Medicaid, and what is their likelihood or risk associated with being readmitted or having poor outcomes. Now, CMS increased that complex patient bonus for the 2020 program year. And the reason with that is because of COVID-19. So rather than being only 5 points, you could see up to 10 points added to your final score. So that is going to be a bonus point called out in your feedback report. You should see some type of bonus point associated. Almost everybody receives a complex patient bonus, but very rarely does anybody receive the full 10 points. Now, quality measures that did have some scoring changing, and some of these were retroactive. You did have diabetes, hemoglobin, A1C, poor control. CMS truncated or essentially shortened the time frame or performance period associated with this measure. Rather than going for 12 months, they truncated it down to 9 months. This does impact anyone that submitted diabetes, hemoglobin, A1C, poor control via claims only. In addition to that, we had a handful of CMS web interface measures that were impacted as well. So we had preventive care and screening for tobacco use. It was completely suppressed. Depression remission at 12 months was completely suppressed as well. And then statin therapy for prevention and treatment of cardiovascular disease was completely suppressed. Now, what this means is it was completely removed from evaluation for your performance if you are using the CMS web interface as your method of submission for 2020 program year. Anytime that you see suppression, it means it's removed from essentially being evaluated. If you see truncation, that means that they are shortening the performance period. It means you'll still be evaluated on it, but you will have a shorter time frame. A lot of these changes were in due part to the public health emergency, and then others were due to changes associated with ICD-10. You'll see kind of in the second to the right column the reasons associated. So with diabetes, hemoglobin, A1C, there is an update to the CPT code set, and that had an impact on the performance. So that throughout the diabetes, hemoglobin, A1C, poor control for the last couple months of the year, essentially. So these are things to keep in mind. These are instances in which you may see what you submitted to CMS change slightly based off of this feedback from CMS in particular. So if you see these changes, do not be concerned. These are known changes. These are okay. Now, we have covered a whole host of information, and we've talked about going to the quality payment program. Robin talked about making sure you have a HARP account. We've talked about making sure you know your eligibility. We wanted to essentially have one slide that you could have access to where all of the different links and websites and contact information was on one place. We know that you all are very busy, and this is just one small fraction of what you do in a month or a year. To reiterate though, you want to make sure that at least one person within your organization has a HARP account and has access to the QPP system on behalf of your tax ID. Now, this is so that you can gain access to that feedback report. It is always important to know what your payment adjustment will be prior to the year, and if you can do so sooner rather than later within that time frame, so that if you find something that is inaccurate, you have enough time to reach out to CMS and contest that information and hopefully set it right. Okay, so I know we covered a lot, and I'm going to go through a few more slides while you'll utilize the Q&A feature to type in any questions you may have. Just a couple of things coming up. So at the end of this month, we do have an improvement activities webinar. And then in October, we actually have an attestation prep. Goodness, it's crazy to think about. And then right now we have a tentative date in November to talk about the 2022 final rule review. This one is subject to change, just like the NPRM one. And that is just because we are waiting on the final rule to drop from CMS. And we anticipate that sometime in the fall. And that could be anywhere from October through December. Last year, I believe we got it on December 1st. So we're kind of hedging our bets and trying to do in the middle. So stay tuned on that. That very well may change, in which case we'll definitely let you all know as soon as we know more. Okay, with that, I'm going to go ahead and open it up for questions. And let's see here. Bear with me just 1 second. Okay, so the first question is, a practice can have more than one security official. And yes, actually, it is something a little bit new, actually, is that you can have more than one security official. And it's really important if you can and you have enough people on staff to have a second security official, especially in the event that somebody falls ill and is out of the office or leaves unexpectedly. Having that ability for somebody to approve, somebody else to gain access or to submit information is really important. All right, it looks like the next question is, where can I find more guidance on the promoting interoperability category? Robin, Colonel, do you mind taking that one for me?
Well, sure. So our favorite website, we just talk about it all the time, qpp.cms.gov, can give you more guidance. There's actually user guides specific to each category on that website. It's under the resource library tab. It's an excellent source. And of course, we, as your advisors, are great tools to use as well when it comes to quality improvement, quality category information, and making improvements in that category. So you got two places.
Absolutely. Thank you, Robin. We also have on our website at KentuckyRegionalExtensionCenter.com or KentuckyREC.com, we have some webinars or videos recorded as well around promoting interoperability in all of the different performance categories. So if you haven't already done so, I highly encourage you to take a look there. Just to let everybody know, the recording will be sent out following today's webinar. It typically takes about a week or so for them to get that out to everybody. All right, let's see, pull up and see if there are any other questions in the chat. All right, so the next question I have is, I have the clinician role and see both a final score and a submission score in my individual feedback. What is the difference? So I think I can take a first pass at this one, and then Robin, if I miss anything, do you mind picking up? So essentially the final score is going to display the group's final score and performance feedback. And whatever is higher of the two scores is essentially going to be what is applied. The submission score may differ because that might be your individual submission that was submitted on your behalf. So if you, let's say, are associated with more than one tax ID, you may have multiple different submission scores, but your final score is going to be the one that's the highest, and it is applied to your individual NPI, if that makes sense.
Yeah, and I'm going to add too, it's one thing we did not touch on today was facility-based scoring. And so sometimes you can submit data to be scored on, but CMS will recognize that your tax ID, or not your tax ID, but your NPI is associated with the hospital that submits to the value-based program for hospitals. And so CMS may go ahead and look at that from the perspective as a facility-based provider. And you could potentially be scored on that side and receive a higher score than what you actually submitted. So that's a perk of being associated as a facility-based provider. CMS is really good about taking the higher of two scores when they look at it from two different perspectives. So I appreciate that they have that flexibility in the program.
Absolutely. I think that's probably one of the best things about it is just whatever is going to get the provider or clinician the highest positive payment adjustment is what CMS tends to take, which I think is very, very nice. Okay, it looks like we have one more question. It says, why is our payment adjustment low when our final score is high? And I think that's a question we get often.
It is, and that's why we refer to it as a budget neutral program. It's legislatively mandated from the Medicare Access and CHIP Reauthorization Act of 2015 that we lovingly call MACRA because it's a lot easier to say. And it was legislated there that this has to be a budget neutral program. So you have the CMS sort of projects how many people they think will participate in the program, and then how many will actually meet thresholds and be above versus how many won't. And they kind of predict what that's going to look like from year to year, but they can't always be certain. And, you know, we know with COVID, it kind of threw a wrench in lots of things. And essentially, the higher CMS is going to keep moving that threshold, that MIPS final score requirement each year, so that it drives you all to participate more and pay more attention to your quality, and you're promoting interoperability category scores. And then those folks that just elect not to participate or can't or whatever, and they can't apply for hardships, unfortunately, they're going to be on that negative side. And that's how that adjustment goes for the positive. It's whatever you're having to pay back in is what's going to fund those folks who are receiving that positive adjustment. It's impacted, like I mentioned earlier, about performance thresholds and about that distribution, you know, that scaling factor. And so that's where you see that. You've got that exceptional performer category that kind of helps boost that positive adjustment, but it's not going to be around forever. And so essentially, we're never going to probably see on the positive side that full 9% that you may see penalized on the negative side.
All right, so thank you, Robin. We'll do one last call for questions, and then if not, we'll wrap up for the day. Okay, well, I thank you all so much for your time and attention today. If you should have any questions or concerns after the fact, please feel free to reach out to us. As a reminder, the recording will be sent out to attendees following today's webinar, and will also be housed on our website. Thank you again, and we look forward to speaking to you soon.